Okay, so first I would like to welcome everyone to Together for Mental Health, Reaching Traditionally Under-Resourced Communities. So this is part two of our series. I love to say the sequel. Everything that's great has to have two parts in it. And what I would like to do is begin by introducing myself and having the panelists introduce themselves, and then we will dive right in. So my name is Dr. Kendall Coker. I will be moderating this panel. I am a clinical psychologist, also an attorney, and I am an associate professor at the University of New Haven in the Department of Psychology and the Department of Allied Health. Now, let me begin by introducing Amelia Burke Garcia, who will start off this panel. And also, one thing that I will ask the panelists is to keep it brief, because everyone, you can find their bios in the chat box. There's a link that will also bring you to the recording of part one of this event. And you can find that on the Global Alliance website as well. So I turn it over to you.
Yeah, thanks, Kendall, and thanks to the Global Alliance for putting on this part two session. My name is Dr. Amelia Burke Garcia, and I'm a health communicator with about 20 years of experience. I have a particular focus on the intersection of digital and social media and health behavior change. And over the past couple of years, I've had the immense honor of helping to develop and lead the How Right Now, or Que Sea Ahora campaign, which has to do with supporting coping and resilience through COVID. And so thanks for having me. I'm really excited for this second part of the conversation.
Good morning, everyone, or afternoon, wherever you are watching us from. So I am Juliana Reese. I am by training a family medicine physician with about 20 plus years direct primary care experience. Most recently, I have taken on a position with the CDC as the director of Healthy Tribes, which is a phenomenal opportunity to really work at the grassroots level in American Indian Alaska Native communities to improve chronic disease and health and wellness. Thank you.
I'll jump in. Thank you, Kendall, and great to be part of this with my colleagues. I'm Eric Windler, founder and executive director of a Canadian youth mental health charity called Jack.org. It started for a sad reason. In 2010, we lost my son, Jack. We didn't even know he was struggling, and he died by suicide. But we decided to see what we could do to help out, and that has led to a significant organization. We have 80 staff and about 3,000 young leaders who volunteer in our programs across Canada. We do something called peer-to-peer education through our Jack Talks program. We have youth-led Jack chapters all over Canada in every province and territory. We train our young leaders through Jack Summits, and we have two amazing digital resources, Be There at BeThere.org and Be There Certificate at BeThereCertificate.org. Just very happy to be here and looking forward to the conversation. So thank you all for attending.
Thank you, panelists, and thank you, audience, for joining us today. Let me begin with the first question. What are some actionable steps that can be taken to expand the understanding and awareness of resources for individual and population well-being?
I'm happy to jump in there, Kendall, if you would like. The way I put this, and we are an upstream organization really trying to build awareness and make people aware of mental health before they're in crisis. But to this question, I think we really need a multi-level approach. It can't just be one way, because we have to really, I call it a multi-prong approach to reach the maximum population. And the four categories I outlined for today would be government, business, influencers, and charities. And there's likely more, but in Canada, I'll give an example. The government recently has started something called the Wellness Together Canada portal, which is a place you can go to find out about mental health. You can receive services or referral to services. And that's government starting finally to take some action. On the corporate side, I name our largest bank in Canada called RBC, Royal Bank of Canada, and they have a foundation that is largely focused on mental health work. They're one of our big supporters. I think of influencers as also critical, and a great example in Canada, and some of you will have heard of a lovely Olympian called Clara Hughes. She was a Canadian medalist both in the summer and winter games. As a speed skater in the winter and as a cyclist in the summer. And Clara has made it her life's mission and she has a huge following to sort of share the importance of mental health and get that out there. And then the fourth category I'd just like to list is charity voices. You know, there are so many charities out there and many are focused on mental health and well-being. And they have, like even as a fairly new charity, we have a database of over 40,000 and we have quite a social following, but we have to reach those individuals in a thoughtful way with engaging content, storytelling, et cetera, to really bring them into this important conversation. That's the upstream side, which is really my focus. I'm going to let my colleagues talk a little bit more about the downstream side of delivery of services.
I can start just a bit. I'm working with programs through the CDC that are focusing on American Indian Alaska Native populations, but the CDC in general it really works from a health equity, social determinant of health model for all populations that we serve. And so we're looking at health disparities, we're looking at big issues that touch all aspects of life and places where people live, work, play, and essentially exist. And so with regard to American Indian populations, American and Alaska Native populations, the strategies that we developed are deliberately designed to be culturally appropriate for the communities that we work in. And it's not just American Indian Alaska Native populations that we do this with. Culture is present in any community, any population that you will be striving to work with. And so the notion of making something culturally relevant and culturally appropriate, the concept of cultural humility is at the essence of what we do. And so with regard to American Indian Alaska Native populations, CDC Healthy Tribes programs really address the notion of cultural connectedness in Native communities and how cultural connectedness is tied to a sense of identity, a sense of well-being, a sense of belonging to a community, and a sense of understanding the cultural practices that have been passed down through generations and generations, essentially for survival of a population. But also these are powerful protective factors for communities. And we are trying to support these cultural practices in a way that promotes resilience, that promotes health, and promotes well-being. So cultural connectedness is one of the essences of what we are trying to promote here. I'll turn it over to Amelia.
Thank you, Juliana. And also Eric. I think my work on How Right Now, I think is a nice sort of touches on both sort of some of what Dr. Reese shared and also some of what Eric shared. And just that it is a communications campaign. And so part of enabling sort of the sharing of resources or the availability of resources is having a mechanism through which you can actually disseminate those, right? So How Right Now in its development was audience-based, audience-centric. We conducted audience-based research in order to develop every aspect of the campaign, from the name to the branding, to the color palette, to the resources that we both developed for How Right Now, as well as the resources that we link out to. And I think that, the ability to share both supportive resources, but also resources that really get at the heart of what Dr. Reese just shared around social determinants of health. When we talk about mental health and emotional well-being, there are a variety of factors that go into that. And nowhere have we probably seen this best, expressed, but except in COVID, is sort of just those disruptions, right? Those disruptions to those social determinants. So people worrying about job loss, food security, housing security, their ability to stay healthy, healthcare coverage and access, all of those have sort of come to light more strongly in the pandemic, and how Right Now really strives to both provide those mental health supportive resources, but also link to sort of the resources that can help with some of those more basic needs that in fact then interact with how we are faring mentally and emotionally. And I think the last thing I'll say on that note is just that How Right Now has been from its inception a partner-based effort, partner-driven effort. Organizational partners from across the United States have participated in the formative research to develop the campaign and its messages. They've been our primary channel of distribution. And it's because we leverage those trusted voices, those voices that Eric talked about, to allow people to learn about and access these resources through people that have been involved in the development of them, but then also that whom they trust for such information.
As you all were talking, I was feverishly taking notes. And what it made me think about, Dr. Reese, well, you all touched on it, but Dr. Reese, one thing that you said more directly was the importance of cultural competence, which then also dovetails nicely into when you were talking about, Dr. Burke-Garcia, around accessibility, especially that this became so pervasive during the pandemic. So my next question has to do with integrating these mechanisms for the purposes of well-being. So given that there are numerous barriers to achieving well-being, which includes cultural barriers, which includes accessibility, such as location, transportation, finances, what is necessary for a full range of mental health resources to overcome these barriers for everybody?
I can start to touch on that. With regard to sort of the actionable items that we mentioned in the previous question, first, it's that general understanding of the community that you're trying to serve, whether that's American Indian, Alaska Native populations, or students, or someone who's in the military overseas, whatever that environment entails. We really want to have the best understanding of the situation. But beyond that, we also have to take the input of the community and really understand what the community's needs are. The community, they essentially are the experts in what's happening and the barriers and obstacles and things that may work in their community. So integrating this open, aware, knowledgeable perspective in really getting the community to express the needs and wants and obstacles from their perspective. And then we as health professionals are trained to kind of put all that together in a way that meets the needs of these communities. And that, I think, is at the essence of trying to figure out how to get over the barriers. You'll have multiple barriers in any plan that you try to roll out, but being able to have the community empowered, have the self-empowered community be able to figure out what works best for them is at the essence of what we want to do. And so that, I think that's something that we could launch off for the other speakers on the panel.
I'll jump in. Thank you, Juliana. That's very helpful. I think a key aspect here is how do we muster government leadership? And I know we say this differently in all countries. In Canada, you would say municipal, provincial, and territorial, and federal. How do you, muster the government leadership to put these things in place? And, healthcare is managed differently in different countries, but in Canada, it's managed, we have what's called a federated model. So there is leadership at the federal level, but it's actually funded and executed at the provincial and territorial level. And to get on the radar of all of these governments is really going to, frankly, take all of our collective voices. And that's why this upstream education about mental health is so vitally important. We talked in the first round about the different ways that can happen, but it's critical that there be enough influence of political leaders and therefore policy by all of us learning about this and caring about it. And not just that mental health is a thing, but how underserved populations are at much higher risk. So that has to be part of this. And it's a big part of our work at JAC.org is to, yes, do the peer-to-peer education of young people across the country, but also to support our young leaders in advocating for changes in their communities, whether that be in a community or a school setting, or advocating, to politicians at the municipal, provincial, territorial, or federal level. But I think it's critical that, and I don't know that this is a fair analogy, but it's been all over my social feeds the last few days about this overturning of the Roe v. Wade situation. And, you can see how certainly a lot of my community is so upset about that. And, but only if there is the mustering of the population at large will that have the effect and end up on political policy decision makers' tables so that they can change the way they're approaching these things. And we have a long way to go in most countries, but I think that would be a critical approach.
Yeah, and I think my co-panelists did a lovely job sort of helping me answer that question. I would just build on what they already shared, that with how right now we went to the communities rather, that we were seeking to support and serve in the early days of the pandemic. We conducted audience-based formative research to hear from them what were the experiences that they were going through and what did they need to be resilient, what did they need to cope. And we tried to pull together and develop messages and materials and resources that would serve those needs. And then since then, we've gone back to the communities. So we listened, we developed some things, we went back to the communities, we tested what we developed, we refined based on that feedback. And then we continuously listened throughout over the past 2 years. We've done ongoing data collection. We've conducted ongoing data collection in order to be responsive as experiences and needs shifted over the course of the pandemic. And up until even just recently in the early part of 2022, when the campaign really pivoted to refocus on where the greatest needs were, as we've seen over the course of the pandemic. And that's really with communities of color, people of color. And so we conducted new formative research with African-American, Black communities, Hispanic Latino communities in English and Spanish, and American Indian Alaska Native communities. And in addition to that, we also worked with some of our old partners and also brought in some new partners in order to get their perspectives of what they were hearing from their constituents and their communities on the ground. I think the biggest lesson here is listen. These communities are going to tell you what they need. And like Dr. Rees said, they're the experts. And so crafting something that works is only going to really work when you actually are responsive to what you're hearing from the people that you're trying to support.
I see everyone nodding their heads, and this makes me think about how needs change and how different populations among different groups, because there's always subgroups, and then their needs also change. So how do we go about modifying accordingly in making sure that we're always able to adjust to meet these changing needs, including ones that are maybe starting to feel a little bit less heard within these populations, because that gets at the heart of intersectionality of need.
For American Indian Alaska Native populations in the work that I'm doing, we are continually making sure we have a standard place where we're getting input, receiving input, reviewing, re-reviewing, evaluating and re-evaluating. And so it is a constant, it's a model that's always changing, that's always evolving, and that's built into the participatory research and culturally appropriate methods that we use. And so it's expected that things will change, that we will be kind of moving with the input that we're receiving from the community. And that's just part of how we do things. So I think it has to be something that's expected. It has to be something that is living and moving and evolving as you go. And that's what makes the work so exciting, because it can be tailored along the way to every community, even every individual. Maybe you have a cultural practice that you're rolling out in a community. Each individual can tweak that particular method or practice to meet the needs of themselves, of their community, of their family, of their situation. And so that needs to be built into what you're doing, is my belief.
Yeah, and I've heard all of you talk about how you're able to make sure you're listening to the community. And Eric, I know you talked about that upstream approach, and through that upstream approach, it sounds like you're always listening to the community as these needs change.
Yes, Kendall, that's the exact word I was going to say to sort of answer this sub question, and that is listening. And it's funny, I was trained by one of our supporters in the very early years as we decided to focus on what we call our youth engagement, youth leadership model. And this very experienced supporter said, never forget, and literally what he said to me was to put your elephant ears on and listen to those young people and contextualize your messaging, your content, the services you're providing. Everything needs to be in response. And it's especially important as you reach more diverse audiences, who I mentioned are obviously at higher risk, that you're figuring out a way to listen to them as well. And I often give the example that in our early years, and it's trending in the right direction, the most engaged young people in our network, candidly, were young women, and largely young white women. And they probably are the least affected by stigma and more likely to be sharing and open about their stories. But it's critical that we reach those underserved populations. The whole demographic of young males is at higher risk, but also the racialized populations, the newcomers, the indigenous, et cetera. We need to figure out ways to reach them so that we can listen to them. Because if they're not engaged in what you're doing, you won't hear their voices. And it's so critical to hear their voices.
And one thing that actually made me think about is how stigma is layered, right? Because one group may experience significant stigma about one thing that keeps them from engaging, which may be different from another group, right? And so when we think about even privilege, right? I tend to say privilege is something you don't have to think about, right? And so when you're able to access resources, you don't have to think about it. When you're able to not think about stigma, then you have the privilege of just being able to get the treatment that you need. And I think a lot of what you all are talking about really also addresses how to overcome stigma, but then recognizing that stigma can affect different populations in different ways, particularly in light of what's been going on in the United States as it relates to reproductive rights, which is also a social justice issue. So my next question is, how do we approach translating experience within and between traditionally under-resourced communities? I can see all of your minds thinking.
I was going to just start with a comment on the word translation.
Okay.
I think that there's certainly a place for translation in all of the work we do. And I'm a communicator, so I know what you mean, but I'm being a little bit more literal here. Mm-hmm. I think it's really important to think about the work that we do as transcreation, because what it means is that you're taking a concept or a model and you're not just moving it over to another community and replacing the figures that are used or the translating the language in exactly the same way. You really are paying attention to that cultural nuance that both Dr. Reese and Eric have talked about throughout this panel thus far. I think it's really important for us to do that. But that doesn't sort of necessarily, I think the bigger issue, right, is the sharing of what is working for certain communities that could be created for other communities. But it sort of gets at some of those nuances or particular cultural aspects that, you know, what you just talked about, Kendall, around one group facing a particular type of stigma and another group facing another type of stigma. What works for one is not necessarily going to work in exactly the same way for another. And I think we just have to be thoughtful about that.
I think it gets back to that listening, Kendall, you know, and that's, Amelia, what you just said is so true. And, you know, I think in our early years, right, we listened to young people and they said, we want to learn how to share our stories. So we developed an evidence-based way to train them. Each of our over 100 youth speakers go through about 50 hours of public speaking training. But in those early years, it was you know, those young people who were more encouraged to reach out. But over the years, we've gotten more and more deliberate to invite, you know, underserved populations to be part of those speaker groups. And most recently, you know, partnering with Indigenous organizations and having Indigenous leaders on staff, but also in our network has been critical because they will resonate so much more with their audiences, you know, and I think that is absolutely critical. Not only that the content you create, you can't just translate it from English to French, you need to also contextualize it for that audience. And you can't just take a regular Jack Talk and deliver it to an Indigenous audience. It makes so much more sense to be delivered through the voice and lens and experience of a young Indigenous leader. So hopefully that's helpful.
I think I want to echo both of my fellow panelists with the words that they've said. When it comes to stigma and really kind of tailoring a message or a need to a particular community, again, our job as health professionals and practitioners is to really do the homework and understanding what that means, not only from a grassroots up perspective, but also from a top down kind of perspective, and figuring out where we can supplement or complement the gaps in the work that needs to be done. One extremely important part of working with American Indian Alaska Native populations is acknowledging historical trauma and the social determinants that have led to this disparities that we see in communities. This is so essential, so critical. Oftentimes people even in American Indian Alaska Native communities don't have a full understanding or may have some gaps in their knowledge of the history that's happened in their lineage, in their family, in their own experience. And so talking about that, bringing it to the forefront, talking about the link between intergenerational trauma, multi-generational trauma, and chronic disease disparities, and what that looks like in American Indian Alaska Native communities can be tremendously eye-opening and tremendously healing. And it really starts you off at a place where people feel like they're connecting whether or not they have those true experiences directly. And so every community has those types of that type of legacy and history that needs to be acknowledged and needs to be brought to the forefront before people can come together to solve some of the issues that they suffer from.
And with regards to that intergenerational basically the way that we really think about trauma as it spreads down through generations also has a very interesting way of keeping us from engaging in services, because it can also have, it makes me think about that other fact where people tend to believe, you know what, we've been through so much, we can deal with this on our own, which then magnifies the trauma because it can end up causing people some reluctance to end up seeking treatment. But the other thing too, Dr. Burke Garcia, that word transcreating is something that's going to stick with me as well. I wrote it and circled it in big letters because one of the mistakes I've also seen in mental health is when they take a word and translate the word into another language, or even when it's in the same language, different groups may ascribe different meaning to that word, which then has an impact with regards to how they even hear it. And I think that's very important and something that I don't think we pay enough attention to, actually. So this brings me to my last question. Anybody that knows me knows that I never have a last question, but in the interest of time, I have to have a last question. And then there'll probably be a question after this. But what are actionable steps or strategies that will support, enhance, and amplify efforts like yours? And you can talk about it, whether it's at the community level or at the policy level. And I think this is an important thing to think about because we are talking about marginalized communities who feel like they may not have a voice. So I throw it out to any of you to answer.
I'm happy to start there, Kendall. It's just being polite. Kind of two aspects to this, and I'll use the examples of our work, and maybe that will resonate, and my colleagues can. So I mentioned off the top in my introduction that one of the things we do is we have what are called JACC chapters. So these are youth-led groups that are in every province and territory. Because almost all young people go to high school, there's a big proportion of them at high schools. About half of people go to post-secondary, so a number of them are at universities and colleges, which is our terminology here in Canada. And a lot of them are in community settings. And these are youth-led groups in these various communities. And we're growing. We're now in well over 200 communities all across the country. And they are really focused on what we call the peer-to-peer education, but in particular, reaching the underserved communities. So they put on events all year long. It's been more difficult these past 2 years with COVID, but a lot of virtual activity, but now they're getting back into it. And they try to reach out and dismantle the barriers to good mental health in various parts of their communities. And that is a key part of, again, it's not somebody from Toronto calling you in Northern Alberta or in Newfoundland. It's somebody from your community who is passionate about this, and you can resonate a lot more. I think that's very important. And we help train those young leaders so they're doing this work really effectively. So that's kind of part one. Your approach, I think, needs to be contextualized to each and every one of these very different communities. But also training those young people, in our case, to do what I call constructive advocacy work. And we often say we like to, when we're dealing with decision makers, we like to call them in, not call them out, and really try to work with them with evidence-based information to provide them for the reasons why these voices are important. And we think that will really lead to constructive progress over time, and really a whole generation of young people who care about this topic so much, understand about this topic so much, and will advocate to those decision makers for policy change at the municipal or local, provincial, territorial, and national level, because all those things need to happen. And it's got to have a real focus on these underserved populations at all time. It's critical. I had a good job when we lost my son, Jack. My wife had a good job. We came from, relative privilege. So if we had known he was struggling, we could have got him some support. But those underserved populations, which are harder to reach, even if they know somebody is struggling, there won't be those services and resources that are appropriate, affordable, and accessible. And so it's a big project we have ahead of us, and we all need to collectively get behind this to do the most good for mental health across the world.
Eric, I think part of what you are touching on is the notion of of course, self-empowerment, community empowerment, but also sustainability. And as health professionals and practitioners, again, it's our job to kind of understand the communities that we are serving, and then to, of course, get that input, embed ways that we can have this continuous feedback of input, and almost like a PDSA model where you're continuously evaluating your input, your outcomes, and making changes as you go, so it's tailored for each community. The partnerships are critical, that the community is able to identify resources there, and that can spread amongst the community that you are working with. But the sustainability is always the trick. I mean, we can have, say we ideally had the funding and we understood all these things, and we go in and we solve this quote problem in a particular community, and then our program ends and we leave. So if we don't embed sustainable ways to keep that going, the program leaves, the community's back to base one, and you haven't done anything essentially. So that's part of what we work really hard to do, and training community members, training youth, looking at our workforce development, our infrastructure and capacity, and making sure that we are acknowledging the community that we're serving and training the community that we're serving to do the things that most people can do. A lot of very basic mental health, behavioral health techniques, if they're just trained to do that. You don't need a licensed professional to handle all of that. And if you can embed the community with coping strategies and tactics and skills that can be continued regardless of whether you have a physician or a psychiatrist or a clinical psychologist on call 24/7 at their beck and call, which of course is not going to ever be the case. If you can provide some sort of stability for the community, that makes a huge difference, and that really promotes sustainability beyond the duration of any program. So again, those are things that we need to be thinking about as the professionals and the practitioners working in these communities, to make sure we're including sustainable methods to continue, and partnerships.
Yeah, and I'll just end with a couple of thoughts. I think that, again, Eric and Dr. Reese did a lovely job, I think, identifying some of those key points. I'm not sure I can add too much more. I do think resources is a really big piece of this, and that's both monetary resources for programs and community interventions, as well as Dr. Reese just mentioned, training up a diverse workforce, having different voices have a seat at the table when these things are in development is critical to ensuring that the focus, is the right focus, and that the right partners are at the table, and that we're listening in the right ways and gathering information from these communities in the right ways. I think having a diverse and robust workforce to help support this is really, really important. And then I would also just say, again, I'm a communicator, so I think continuously talking about these issues is incredibly important. For too long, I think if you listen to the first part of this conversation, for too long, the issues of mental health and emotional well-being and behavioral health have gone sort of unacknowledged, or they were less important than other more critical issues. And I think in the pandemic, we have a moment, unfortunately, but maybe there's a silver lining to it, where mental health has really become part of our sort of, it's risen in sort of our consciousness of like what people have experienced during this time. And we shouldn't lose sight of that right now. And I think keeping the conversation going, keeping programs that support communities in the right ways active and communicating is critical for us to continue this and have some real impact, but also longer term sustainable impact.
Right. Eric, there's a question that has been directed to you in the chat, and the question is, how have you ethically and successfully engaged youth and parents in sharing their mental health stories without fear of stigma and prejudice? And they go on to say, unfortunately, it is still tough to share and then be recognized in your community for that aspect of your life without it defining you.
Yeah, thank you, Kendall, and thank you, Michelle, for that thoughtful question. And I'm going to sort of tell you quickly the story. We lost my son in 2010, and we actually partnered with our National Youth Crisis Line Kids Help Phone for 2 years and did a pilot study to develop our approaches. And then we tested the model with Queen's University, where my son had been, and tragically they lost 6 students the year they lost my son. And so they were very engaged in the work. And we landed on this youth engagement, youth leadership model for the transition year. So our focus, parents are like a secondary audience, but our primary audience is youth in the transition years, which we call age 15 to 24, because we know that 70% of the onset of mental illness is at that time. So specifically for Michelle's question, the very first year we had our National Jack Summit, this was actually during our year at Queen's before we became an independent charity. And we had 200 of these young leaders, flew them into Toronto for this weekend of activities. And I'm just going to tell you the story very transparently. This one amazing young leader stepped up to share her story. And this is before we really had all the expertise that we've developed over the years. And she was a tremendous speaker, and she had a very authentic story. And we gave her 7 minutes to share her story. At 12 minutes, so she went over, at 12 minutes, about 20 or 25 of the young people in the room had left the auditorium. They were so triggered by how she told her story. It was very authentic and very well said, but we learned from that, and then we dug into the research about how you have to share your story. And it reminds me, I was at another conference at about the same time, and a young man was sharing his story about repeated suicide attempts and trauma in his family and all the rest of it. And that was very triggering as well. And so we've learned from the best evidence about how to train our young leaders who are sharing their stories to do so in a non-triggering way. And yes, it's okay to mention that you have struggled with your mental health, and at one point you were suicidal, but you can't do it in a really graphic and unacceptable way. But we've built that into the training that these young leaders get. And what I would say about the second part of the question, our young leaders, they don't mind this becoming what they are about. They are so passionate about this topic of mental health and so open about sharing their stories. It is what they become all about. I call them the varsity athletes of youth mental health, because they really, they don't mind that. They realize how much good it's doing. And, you know, you can see in a Jack talk, for example, if there's 300 kids in the auditorium, at the end of the talk, there'll probably be 10 or 12 of them in lineup to talk about how much they appreciate hearing those stories from young people. But to Michelle's question, it has to be done in a very safe and appropriate and non-triggering way, or else you're doing more damage than good.
Dr. Reese, this actually also makes me think about some of your work as well, because you talked about the intergenerational trauma that your population experiences. So I'm wondering, do you find yourself also having to address this in some ways or deal with it in some ways, given that the population you work with has experienced prejudice, stigma, and some of these other historical trauma-related issues?
Absolutely. I think more often than not, I'm asked to do talks on historical trauma and on the connection between intergenerational trauma, ACEs scores, multi-generational trauma, and chronic disease, and what that looks like in Indian country, because there are differences. And oftentimes American Indian Alaska Native populations have been, historically, have been expected to kind of fit in with the American culture and have had to essentially adapt themselves to meet the comfort level of other people around them. And there's this huge notion in society, by a large proportion of society, that this idea of what American Indian Alaska Native populations is very stereotyped and stigmatized, or kind of Hollywood. There are all these stereotypes of what an American Indian Alaska Native person or population is, and there's very little knowledge of the complexities of American Indian Alaska Native populations, the diversity in tribes, the diversity in languages, in cultural practices and traditions. And so it feels like we have to start almost educating even ourselves as well as the general public before we can even begin to start doing the work that we want to do. That's just a part of the work. And other populations don't necessarily have to do all that. There's just general knowledge of stuff. There are different health systems and different relationships with counties, with states, with the whole notion of tribal sovereignty and data sovereignty. Those issues compound a lot of the work that we try to do in an appropriate and respectful way. So it takes a lot of education on the forefront and along the way, not only to the communities we're trying to serve, but also to the general population, and then to where we get our resources from, and folks that are going to be partners, and the people that we network with and the organizations that we work with. It's a constant educational process.
And Dr. Burke-Garcia, are there ways that you find, or that you see, the way that the message should or can get out in order to address this issue as well? Because I know you take a very mass media type of approach.
Yeah, so I mean, I think, you know, the use of storytelling is incredibly important. I think what we saw in our evaluation of how right now it was our first year evaluation, is the messages that resonated the best with our audiences were messages that first acknowledged what people were going through, and second provided an actionable step that they could take to start to cope. And I think it's not a one-to-one, but we see similarities in what Eric and what Dr. Reese just shared around acknowledging, telling that story, but also sort of providing some context or some other aspect, tips or how somebody else has gotten through as part of that, so as to sort of contextualize the story in a way that doesn't both put people off or trigger people in the wrong way. And so I think that we see some of that similarity in some of the work that we've done and in our own data. And I do think that this idea of, you know, in the communications literature, right, just talking about fear appeals, just telling scary stories is actually proven not to work very well with people. And so I think it aligns with a lot of the prior work that's been done just more generally in the health communication space.
Okay, and I'll now direct this next question to Eric. And I think Dr. Burke-Garcia, your explanation just now also touches on this with regards to the research. But Eric, what did your research show regarding positive and effective ways to share your story?
Well, I'd have to chat to the evaluation team to give you specific details, but I do recall we landed on some very specific research that showed the appropriate way to do that. And you know, I'm kind of going on a bit of a tangent here, Kendall, but you also the question also dealt with, you know, parents as well. And I think being authentic with the young people in your life about some of the struggles you went through is also critical. You know, and you know, from an older generation, and you know, the generation before me, I think the habit was just only talk about how you were so strong and how you did so well and you got through everything. You have to be authentic with young people, especially, that you had some struggles too. And that really commonizes this discussion so much and makes it much more likely that they will open up when the time comes. You know, did my dad ever tell me that he, you know, struggled with his mental health or had trouble with, you know, his math course or this or that? No, I only heard about how and I don't blame him for that, but that was the culture of the time. We often call it the rose and thorns. You need to, when you're talking with young people in your life, you need to share the good things that have been going on, but also the tough things that have been going on, because that will encourage. And so it's the same as when a Jack Talk speaker is sharing their story. You can immediately see the audience resonating with that, because a significant portion of the audience also struggles. And this commonizes that discussion. But doing so in a non-triggering way is critical and follows best evidence. I hope that's helpful.
And I think it highlights the importance of also getting research out there, because there is a lot of misinformation regarding how to have these discussions. So I'd like to thank the panelists for talking about the ways that research has been and can be used to have these difficult discussions. Dr. Reese, there was a question directed to you. How will you start a community training relating to mental health? Like, what do you envision this training? Does it need partnerships with other groups?
Wow, I love the question. Thank you, Molly, for asking the question. As I mentioned before, I'm a clinician at heart, and I have always been interested in public health and community-based initiatives, and I have spent my career trying to bring those two entities together. Very difficult from both sides of the equation, but we're right now working on a draft proposal to kind of look at this very idea in Indian country. And really what it boils down to is what I kind of touched on before, this idea of sustainability and empowering the community to be able to do some of these things on their own to build those protective factors and build some resilience, at least until the time when we can be able to have a more comprehensive approach offered to every individual. And so the idea of meeting the individual where they are is really at the key of this idea. And what I would envision is being able to take very simple curriculum like motivational interviewing, coping strategy theory, behavioral activation techniques, those three at least. There are already developed curriculum out there for people to be teaching that. I mean, I got that teaching in residency and in medical school. I teach it all the time. I use it in all of my patient care encounters. Very easy to train people to do these kinds of things. You don't need any kind of special education per se. And so if we could be able to pull together a curriculum and make it culturally relevant, culturally appropriate for the community that we're serving around these three types of modules, and then go out and actually teach community members these types of things, whether it's traditional healers, it's youth, it's first responders, community people in general. We've actually had community members ask for training. This has been something at the forefront of discussions for tribal advisory meetings, where you have community members saying our suicide rates are the worst in the nation potentially, and we need help with this. This is what we want. We have a system that's so complex, where we have an Indian health service system that is traditionally has been under resourced, and once you get in the system, you get tremendous care. It's, again, that whole idea of being able to get access to that, depending on where you live, how rural your situation is, how complex the problems and barriers are in your community. And so being able to, say, a family member is experiencing suicidal ideation, and the parents or the sister, the brother, or the neighbor wants to be able to intervene because this may be a recurrent thing that's happened, and for some reason this has been triggered. This is a real scenario with a patient, a past patient of mine. that patient was obviously taken to the emergency room, went through the process, and told that they would be able to get in to see a psychiatrist and a counselor in the next 3 to 6 months. Now, that's tragic, because this person, again, meeting the individuals where they are is what our intent is. And if we were able to provide some sort of coping strategy, some sort of mechanism that's embedded in that family, in that community, there might be ways that we could support this person until they could get, at least until they could get the help they need, or maybe even help develop strategies that would inadvertently not have to require admission to a mental health institution or admission to an inpatient facility, you know, all these things. So it's about meeting the person where they are. And that would be my approach to coming up with, say, a pilot project first to start that sort of thing. But again, the key would be making that material culturally relevant to that community that you are focusing on.
Thank you. Now, as we conclude this panel, because I know we can go on for hours, and I would like to thank the audience again for their wonderful questions. Can each of the panelists give me about 30 seconds to 1 minute final thoughts that you would like to say as like a take-home message to end with? They had so much to say before, right?
I'll jump in, Kendall, and there is so much to say, and we're just grateful for you and for Geeta to arrange this and just, you know, share our work and share the importance of this critical topic. I also want to just reflect on something that, you know, as Juliana was speaking there, that reminds me, and I want to remind the audience, underserved populations. And so I'll use Indigenous, for example. I think there's 7 times the rate of suicide. If you think about that, and underserved populations struggling to a greater degree, losing more of their peers, imagine the follow-on trauma that creates in that community. And, you know, I happen to be dealing with somebody from our community who lost they reached out to us after they lost their daughter. And, you know, she's going through the worst of it right now and really struggling and having trouble going on. But imagine that in communities where a lot of this is going on. And it's so important that we help those underserved communities. And I just want to thank you all for really making this a focus of these conversations.
And I'll just add that the importance of ongoing data collection and research to understand evolving needs. The idea of one evergreen message that fits everyone, I think, has gone by the wayside a long time ago. And yet we still see that out there. And not only that, but we see these needs emerge and change over time. And it's just really important to keep listening and keep evolving and keep supporting in ways that are relevant depending on where people are.
I think this network is the essence of sustainability, holistic vision, and application of efforts. And doing more things like this, where we're bringing in different perspectives from different groups and different methods of addressing the community is huge. It's again about this connectedness, the network of connectedness between all of our entities, and forming some sort of way that we can partner and share the message and communicate that.
Thank you. And where I think I will end is that this discussion makes me think about resilience. And the reason why I find resilience to be so important to communities is, as you all were talking about sustainability, we also recognize that policies are not always on our side. And communities, especially ones who've been marginalized, are marginalized because policies have not always been on their side. And finding ways to enhance that community's strength, I think, really matters. And helping communities recognize that just because you may have lost one fight does not mean you leave the fight. You have to be able to be resilient. And I think that's a very important message. And I think that's very commendable for the work that you all are doing to help communities continue to be resilient and strong in the face of adversity, because these are important issues that hopefully this is not a discussion that ends and that everyone is having them. So I'd like to thank the panelists again. The only thing about having these things on Zoom is you can't have everybody clap, right? But I'm sure everyone is clapping. So thanks again to the panelists, and thank you to the audience for taking the time out of your day to join us in this important discussion.
Thank you all.
Thanks, Kendall. Thank you.
Bye-bye.